Good evening, everybody. My name is Dr. Dan Bensimhon. I'm an advanced heart failure cardiologist at Moses Cone Hospital in Greensboro, North Carolina. We'd like to welcome you to the webinar this evening and thank you for joining us at the evening hour and sharing an hour of your time with us. We have a distinguished faculty today, and we'd like to share some experience with you about the use of ReDS technology for heart failure. Before we go any further, I would like to mention that the program tonight is being recorded. So if you would like to refer back to it at any point, we will have that available and also to be able to share with your colleagues. As many of you who treat patients with heart failure know, when treating these patients, part of the difficulty of treating patients with heart failure is realizing who's fluid overloaded and who isn't. And sometimes that can be quite a challenge, especially in larger populations. At our center, we've been working with various technologies, and over the past 5 years, we've become very in tune with the ReDS technology. We've used it in multiple points of care across our hospital system and our clinics and our communities. And we've enjoyed it, invited some faculty to join us about their experiences as well. So we'll start with I'll give a little bit of introduction, and this is really our faculty show about what they've done. After each presentation, you'll have a few minutes to ask questions, and then we'll move on to the next presentation. There'll be about a 10 or 15 minute question and answer session after the presentation as well for a panel discussion. So once again, thanks for joining us, and without further ado, we'll jump into our presentation. If we can have the next slide, please. So I think most of you know the problem with a decompensated heart failure is really congestion. About 90% of people who get admitted to the hospital for congestion. And congestion drives most of the symptoms, as you can see, of heart failure. There's a small percentage of people who also present with low output symptoms, but this is by far the minority of our patient population. Plenty of studies have been done about this, and it's not only the cause for more frequent cause for hospital admission. Residual congestion is also associated with reduced quality of life and worse outcomes as outpatients and after hospital discharge. Next slide, please. We've done a lot of work over the past few years with implantable sensors and monitors, and we've learned a lot about the patterns of congestion. I think many of us used to think that patients develop congestion fairly rapidly, and then we have to intervene quickly. But if you look at the data from the sensors that we've developed over the past a decade, what you'll see is that the process of decompensation leading to hospital admission is really usually a couple of weeks long. What you see is that filling pressures begin to increase. There becomes changes in the autonomic nervous system. Then you see changes in thoracic impedance. And then the symptoms we're aware of, weight gain, shortness of breath, orthopnea, P&D, are a rather late presentation in this cascade. And unfortunately, at that time, that's also the time when diuretic resistance is increasing. So if we wait till symptoms develop, often we've waited too long, and we can't prevent the decompensation well enough to keep the patients out of the hospital. So it's really important to start detecting these patients early and detecting changes in filling pressures and lung water early so we can respond effectively. Next slide, please. That'd be great. Yeah, keep going. So I stole this slide from Dr. Bill Abraham, who's a good friend at Ohio State. And, Bill is probably the world's expert in implantable sensors and detecting volume decompensation in heart failure. And, with Bill's experiences with the device, Bill's mantra is always that in order to be effective, a device that measures or detects lung fluid or to help manage heart failure should live by the 5 A's. And what Bill means by that is, first, we must have appropriate signals. The sensors must detect what we want them to detect without much noise. So in the case of heart failure, we want them to detect the appropriate signal is lung water. We want them to detect congestion. Secondly, the sensors must be accurate. These must be tested sensors. They must be validated. We must be able to get accurate and reliable measures. Third, the sensors must be absolute values and not relative ones. And this is really points at what we see with biomarkers. I think we all use BNP. We like BNP, but if we're doing a spot measurement in a patient with a BNP and they have a BNP of 500 and we don't know their baseline, they may be perfectly dry or they may be very overloaded. So it's the absolute value, which is really important when having a technology that works for point of care use. And then the information must be actionable. So you must be able, if there's fluid overload and that you detect a high level, if you can act on that and show that you decrease that level in an appropriate fashion, that's important as well. And we'll show you with ReDS, if a significant decrease in lung water is accompanied by a 4% decrease in ReDS lung water readings. And then finally, there must be treatment algorithms based on the findings of your numbers, and you must be able to follow protocols and algorithms to treat people effectively. So this is where the ReDS technology comes in. As you're aware, this is a device coming out of the Israeli military, and it's designed to see through walls. There are sensors on the front of the back in the patient. How much fluid content is in the right middle lobe of the lung. Next slide, please. You can see here, there's the sensor on the front, there's the sensor on the back. This is not impedance, this is a radar beam. This is a similar technology, as I said, to what the military uses when they're looking at the destroyed structures or rubble in a house. They use this to find bodies and other things. This is very highly specified technology. The normal lung water measurement in the normal patient is 20 to 35%. It takes about 45 seconds to take this measurement in the clinic or in the hospital. You can put the sensor on top of clothes. You don't have to worry about skin contact. The technology has been well validated against the gold standard. This is the gold standard of measuring lung water is computed tomography or chest CT. And you can see a very, very tight linear correlation here between the ReDS measurement of lung water in the right middle lobe and what we see in CT scans with an interclass coefficient of 0.94, an R squared of 0.94. Next slide, please. We've tested this. This is Neal Uriel's work. Neal was formerly at the University of Chicago. Now he's a good friend, and he's at Columbia University running the transplant and VAD program. Neal did checked ReDS readings before Swan-Ganz catheters. They did it in the holding area of the cath lab as the patients were going for a Swan-Ganz catheter. And you see a few things here. One is there's a very good correlation between ReDS readings and elevated pulmonary capillary wedge pressures for Swan-Ganz readings. What was very impressive about Neal's study is the negative predictive value of this test is 95%. What that means is if this test says you are dry, you are absolutely dry. It's much like a D-dimer in the fact that a D-dimer has a very high sensitivity. If it says you're dry, you are dry. There was a 10 or 15% false positive rate where sort of men with bigger chests can have elevated readings once in a while. But for the most part of the population, we had very, very good correlation with wedge. And it was also able to distinguish between right heart failure and left heart failure. So if somebody had a lot of edema, a lot of peripheral edema, but their lungs were dry, that correlated with the patients having RV failure. Next slide, please. This is designed by the team at Geisinger. This was a ReDS sort of overview or protocol designed by the team at Geisinger, Dr. Dadamani and team. What they said, the ReDS reading between 25 and 35 is really the sweet spot. 35 to 41 is mildly elevated, and 21 to 24 mildly decreased, but could be within the normal range. And then you can see higher numbers and lower numbers there. In our clinic, we have found that patients with chronic heart failure will often run in the 36 to 38 range and be okay. But once they get to 41, 42%, it correlates very, very well with symptoms of orthopnea and PND and increasing exertional dyspnea. This was the initial trial done in Israel on a group of patients. This is a group of chronic heart failure patients who used ReDS technology for 3 months at home. and they had daily measurements of their volume, and these were responded to with increasing or decreasing diuretics. What you can see in the patients, this is looking at readmission rates. What you can see prior to using REDS, there's a very high readmission rate for this patient population. In the 3 months that we were using REDS on this population, we saw an 87% reduction in admission rates for heart failure. When we took the device away and let the patients go back to their old habits, then the readmission rates went back up, and you saw a big increase in admission rates. So this was the very initial data of 50 patients of how this device functioned clinically. We got our first devices back in 2016, I think, and we were trying to understand how we were going to use these devices and what point of care was most effective to use the devices. Well, we did two things initially. The first thing we did is we kept the device in clinic to see how comfortable we were using the device. And we had our heart failure NPs, we had the physicians, and we had our nurses sort of guess have them estimate what they thought the lung water was, high, low or wet. And the heart failure physicians and the providers were pretty good. 70–80% of the time we got it right. But the pharmacists and our nurses were about 50–50. They're excellent heart failure providers, but they had a difficult time assessing lung water. And so we realized this was going to be an important tool for us to treat our patients. And then finally, we went from the ED to hospital discharge into various places. And you can see that at the time of discharge for heart failure, 32% of patients were still markedly volume overloaded, and 11% were moderately overloaded. So 43% of patients getting discharged from our hospital still had a significant volume overload. 40% of patients who presented to the heart failure clinic had residual volume overload. And when you look at the ED, the story is a little bit the other way around. In the ED, 1/3 of patients who presented to the ED saying, I have heart failure, were actually dry. So we're really using this technology in our clinic, not only to make sure that we're adequately diuresing these people, but also being able to triage people in the ER saying, maybe you're low risk and you can go home. So without further ado, what I'd like to do is turn this over to our panelists and let them tell you about their experiences with treating heart failure with this device. So our first panelist is Allison Neal. She is did this work at Allegheny Health Network, and Allison, will turn it over to you.
Thank you. So around 2014 to 2015, Highmark came to Allegheny Health Network and said, what can we do to work on these heart failure readmissions? And that's kind of when the first start of the heart care program was started and developed to, one, kind of try to reduce heart failure readmissions, but also to provide a continuity of care and close that gap between acute hospital care and post-acute care. So what we in turn developed over the next few years was a program where we partnered with skilled nursing facilities and home care companies and provided them with extensive education training, simulation on really the best way to care for heart failure patients. This also turned into a team that was, started in the hospitals, and it was all of Allegheny Health Network hospitals from Pittsburgh to Erie in Pennsylvania to streamline this process of how we can narrow the network and send our heart failure patients to a facility that has been trained on how to care for heart failure patients. So next slide. So this is kind of the model we use to determine risk of the heart failure patient, which was started, as I said, in the hospital. We would have nurse navigators, find these patients, see how high risk they were, and then they would actually provide education to the patients while they were in the hospital. But as we all know, not a lot of that education can be retained while patients are in the hospital. So then in turn, we would, if the patient was agreeable, we would send them to one of our partnered facilities. And at that facility, they would get the same education and everything that they were told in the hospital. Next slide. So the education that was provided was through a Highmark team that would actually go to the facilities and provide the nursing staff, the CNAs, the therapy, pretty much everybody in the facility with this education. It was not extensive, crazy education. We did not reinvent the wheel. We simply were providing them, you know, with the education and resources to most effectively care for the heart failure patients, like weighing the patient daily, low sodium diet, the right medication, guideline-directed medical therapy, all the things you're supposed to do that, you know, just kind of at times got lost when they went to the skilled nursing facility. Yeah, that's fine. When we would go to the facility, so you can go to the next slide. We would develop a facility champion, and kind of that would be my contact person. So originally when this started, we had daily huddle calls. It moved to 3 times a week huddle calls, where essentially every day I would touch base and go over all this information on each one of our patients that were in the facilities and that we were following. I would make, you know, based on this information, medication adjustment, titrate medications, monitor lab work, and so forth. So that was kind of the overview of the program. And then we kind of had partnered with Vitals and Highmark again to implement ReDS. So if we go to the next slide. ReDS device to see if adding the ReDS device to this program that we have kind of already started would help to in turn further reduce readmission rates. So we did 4 of the facilities that were already previously trained in the education of caring for heart failure patients were then given ReDS devices. I believe we were able to purchase 2 of them, one through Allegheny Health Network, one through the Vitals, and then we leased one of the devices for a while. And then I think in turn, by the end of it, we ended up buying the 3rd one as well. So we had Sensible Medical actually physically go to these facilities and teach 2 to 3 of our facility champions how to use the device and how to monitor the patients. If you want to go to the next slide. So we had the enrollment criteria of a patient that was, you know, had either a history of heart failure or had heart failure and was in one of our AHN hospitals and in turn going to one of our partnered SNFs. So we, as you can see, we had a total of 131 participants and 112 of them were clinically managed with the ReDS and 19 of them with the reasons listed there. I would say that most often it was a BMI that was too small rather than too large, and then other simple just patients that did not want to do it or so. So this is kind of the main slide of our results that we found. So you know, after a 30-day pre-program, so this original number of all-cause readmission, 28.7%, that was taken from facilities that we were partnered with, the patients that I was following in 2017, compared to once they had been in the program. And I believe the dates were from October 2018 to August 2019, the 30-day readmission rate while using the ReDS device dropped to 18.7%. So we really did see some good results in monitoring these patients, along with you know, doing the ReDS reading and then having the daily weight with it and the symptom management and kind of getting that whole clinical picture. Some other oh, I don't know if I mentioned, the way we would do the monitoring, it says daily in this slide, but it was actually Monday, Wednesday, Friday, we would get readings on them, and then on admission and on discharge. So they were getting readings 3 times a week. And then as a comparison of the facilities that were using the ReDS device versus facilities that we were still partnered with not using the ReDS device during that time period, the heart failure all-cause readmission was 18.7% 0.75 for facilities using the REDS, and then all-cause readmissions over 30 days for the facilities not using the REDS, 24.11. And then that's with the whole entire 112 population. We were able to do primary diagnosis of heart failure to kind of primary heart failure to heart failure readmission in the facilities using the REDS device was from 4% to, though non-REDS device heart failure to heart failure readmission was 22.22%. But the patient populations for those testings were kind of a lot lower. It dropped down to 25 and 27. So I really do wish we could have kind of taken this out a little longer and to see some more results, because I think we were getting really good numbers, but we had kind of very good results.
Ali, that was phenomenal. We're going to open up for any questions. One question, while we're taking a question or two from the audience, one question I would like to ask you is, you know, in our experience with the REDS technology, one of the most powerful things about the device is that it really helps you dial in on the right diuretic dosing. When patients come out of the hospital, their diuretic resistance is usually less, and they're restored to their diuretic sensitivity. Did you find that it helped you find the right dose of the diuretic? And once you found the right dose of the diuretic for a particular patient, they sort of were more stable on that dose? You know, in our center, we say, once you got them, you got them. Did you find that as you got them stabilized, you needed less changes as the time went on?
Yes, definitely. I think that it was a definite great thing to add to the whole entire clinical picture. But I do agree that, you know, I think the biggest impact of it was when you didn't see those changes of a drastic weight gain or shortness of breath or swelling. You know, maybe all those were very minimal. You saw that REDS number went up. It was a very early indicator to kind of say, okay, this patient needs a little help, you know, a little more diuretic, a little something, and then we could kind of get them back. I think that there was less catch up, like playing with that when you found, you know, that once you kind of got them back down to whatever their normal number, which when you're using the device that much, you kind of get a sense of patients' normal numbers, that you can kind of stabilize them on their diuretic and not having to do so much, you know, 3 days increase and then go back down, and then a week later, 3 days increase.
Right.
So you do agree with that.
Yeah, I think that's great. Do we have a question or two from the audience before we move on? Thank you, Ali.
Thank you.
You can either type in the chat or just come on and say your question. Well, that's great. I don't see any questions popping up. We will move on now. Next speaker is Craig Laing. Craig is a nurse practitioner. He's the lead nurse practitioner at the Advanced Heart Failure and the Mechanical Circulatory Support Program in Christiana Care, Newark and Delaware, which has a really an amazing program, not only an amazing cardiology program, but also a really amazing community outreach program. And we've worked with their center in the past. And Craig, we're honored to have you, and I'd love to hear a little bit more about what you did.
Thank you very much. Good evening, everybody. We can go ahead and do the next slide. So I'm going to be talking tonight about utilization of REDS vest and IV diuretic clinic. We can go ahead to the next slide here. A little bit of a background about our program here. We are an extremely large volume heart failure program here with just over 1,900 heart failure discharges last fiscal year. In our advanced heart failure clinic, we have about 5,000 encounters during that time period. So, you know, certainly we see a large share of heart failure in our institution. And in order to, you know, make significant changes on outcomes requires outreach to a lot of patients. So if we go back to fiscal year 18, our 30-day readmission rate for the institution was around 20.5%. Higher than the institution wanted it to be. And so we were looking for innovative ways to reduce that readmission rate. And we had created a nurse practitioner-led IV diuretic clinic in March of that year. We piloted the program with our advanced heart failure patients and ultimately opened the entire program up to the cardiology section throughout the hospital. And then later in the spring of 2018, we incorporated REDS vest utilization within the diuretic clinic. We can go to the next slide. So our process for our IV diuretic clinic, just like any heart failure patient, starts with the physical exam, discussion with the patient of their symptomatology. Now we've incorporated REDS vest reading as another vital sign for every heart failure patient seen in the heart failure clinic, not just the diuretic clinic. And we've established protocols that if their REDS vest reading is greater than 50%, they receive IV diuretics in the clinic with an adjustment of their oral diuretic. If they're between 40 and 50%, we leave that up to the clinician discretion for IV diuretics with adjusting their oral diuretic. And below 40%, generally we don't give IV diuretics or make changes. Certainly these ranges we've established here are up for discretion of the provider based off the patient's symptomatology or weight gain or other findings on their physical exam. We can go to the next slide. And so we've created this process for referral for IV diuretics. This, like I said, is open to anybody within our cardiology section, not just those in advanced heart failure. But they're seen by a nurse practitioner on their initial IV diuretic visit and has a REDS vest reading done. If that REDS vest reading is normal, they're returned to their primary cardiologist for further management. If they're noted to have symptoms of congestion and an elevated REDS vest reading, we've established a protocol that patients receive 80 milligrams of IV Lasix in the office. We have the availability to do point of care lab testing right in the clinic, so we're able to get a quick chemistry panel on them. Initially, we were concerned about renal function. However, in discussion with our nephrology colleagues, the feeling was that we just ignore the creatinine and diurese them if needed. About the only patients we will not give IV diuretics to are patients with serum potassium levels less than 3, just due to the risk of further hypokalemia and ventricular arrhythmias. Any patient that receives an IV diuretic will also have an adjustment in their oral loop diuretic, and they're scheduled for a 1-week follow-up back in the diuretic clinic. So when they come back for that second visit, they again get the REDS vest reading. We're looking for improvement in those numbers from the week prior. If the REDS vest is normal, they're feeling better. They no longer follow with us, and they'll return to their primary cardiologist. If we find that their REDS vest reading still remains elevated, we'll give IV diuretics again and bring them back for a 1-week follow-up for a third visit. Much like the second week, we'll do the REDS vest reading at the third week visit. If it's normal, they go back to primary cardiology. If it's abnormal, we'll do another dose of IV diuretics, adjustment of their oral diuretic. And we actually refer these patients automatically to one of our advanced heart failure cardiologists for a follow-up appointment, looking for features of advancing cardiomyopathy that may be hiding out there in the community. We've actually had 2 patients that were referred to our IV diuretic clinic that progressed through to needing to see one of the heart failure cardiologists and ultimately ended up receiving an LVAD after coming through this. So it's a way to not only grow your heart failure program and your LVAD program, but also provide the patients with a level of care they're not getting. We can go to the next slide. We created in our electronic medical record a tracking tool that we can follow these readings. So whoever does the REDS vest reading is able to enter the chest reading, so we can refer back to what their chest size was and what the REDS vest reading actually was, and then the provider that was notified. And that way, if we're seeing patients in the hospital and now we're following them up in the clinic, we're able to go back in and look and see what their reading was while they were hospitalized and diuresed. And now when we're seeing them outpatient, what improvement we've seen, or if we're seeing worsening numbers from visit to visit, we can go back in and look. This is also beneficial, as Dr. Bensimhon was mentioning in the studies for this, looking at wedge pressure for our patients in the advanced heart failure program that are getting a Swan-Ganz catheter done. We'll actually slap the vest on them prior to the cath. And it gives us a baseline marker that when we correlate what their wedge pressure is, when we see them on successive visits, we know what that will correlate with their wedge. We can go to the next slide.
Kevin, administrative stop for 1 second. We need to change presentation, okay? Just 1 second, sorry.
Greg, I'm gonna ask you one question here while Ron's changing the slides. You know, we have been very impressed by the ability of the device to identify patients with cardiorenal syndrome. So they look volume overloaded. You get a reading of 42%. You give them 80 milligrams of IV Lasix, and we expect a 4% decrease or more in the REDS reading. If we get no decrease or 1% decrease, we start worrying about cardiorenal syndrome and other factors. Is that something you noticed in your clinic? Did you
so if you can eat a high sodium diet and drink your fluid, the amount of diuretics we give you in the clinic once or twice a week is not going to cut it. But in those patients that we're seeing in successive weeks and we're not seeing the improvement, that's really where we incorporated that transfer to the heart failure cardiologist. And now we're starting to evaluate for those patients that have the features of advancing cardiomyopathy and trying to get them before they get on dialysis with their renal dysfunction. And is this just an issue of their early low output and they need to go on inotropic therapy, and we see improvement in their renal function then?
Right. I think that's really well said. You know, I think it really helps determine who's gonna be receptive and who's not. I think you have one more slide, right?
Yes. So if we can go back one, yeah, there we go. So as I said, every patient in our advanced heart failure clinic gets a REDS vest reading done every visit, if able to. Obviously, BMI is the big one that we cannot get. Any visit in the heart failure clinic can become an IV diuretic encounter. So if I'm seeing somebody or one of my other nurse practitioners or cardiologists are seeing a patient for routine follow-up and they're noted to be volume overloaded by REDS vest and or physical exam, we can grab our nurse to come in and do diuretics right then and there. When we started this in 2018, we saw 170 patients, up to 237 in 2019, 373 last year. This year, we're a little bit further behind. You know, coming out of COVID and some staffing challenges here, we've become a little bit more selective of who we see. Part of what we've done also is we've worked with our visiting nursing group through our institution. That we've created a home REDS vest program that patients that are discharged from the hospital with a heart failure diagnosis and sign on with our VNA can also get the VNA to come out and do REDS vest readings in the home and do IV diuretics in the home. So we're taking that IV diuretic clinic from the hospital and delivering it to patients who may not have the ability to get to our office and see us. We've incorporated this on our inpatient unit, and it's really guided our diuretic therapy management on the inpatient side. And in 1 year of the IV diuretic clinic, just utilization with the advanced heart failure program, we were able to drive down the system-wide 30-day readmission rate by 3%. So obviously with a volume like we have of 1,900 discharges, to get a 3% reduction is hundreds of patients that we've been able to keep out of the hospital on a 30-day readmission. So.
Yeah, great work, Greg. Thank you. Thanks for your time.
Yeah.
Just great job up there. And tell Dr. Banerjee we think he's doing a great job. In the interest of time, we're gonna keep rolling on a little bit here. Our next speaker is Kevin Castano. Kevin is a pharmacist, a cardiac specialist pharmacist at Lakeland Regional Health outside of Tampa. Kevin has done extensive work in creating a program with REDS. It's near and dear to my heart. We have a large program in our hospital that's run by our heart failure pharmacy team that follows all patients admitted, helping them guide diuresis with daily REDS measurements on our heart failure floor. So no further ado, Kevin, the floor is yours.
Thank you. All right, next slide, please. Next slide. Oh, there we go. Like I said, I'm Kevin. I'm down here in Lakeland, Florida. We're pretty much in infancy or babiness when it comes to using REDS. We kind of just got started really just the end of last year was our beginning usage. We're a very large hospital. We're 850 beds. We do advanced cardiac care. We provide all the cardiac services. Really, we do everything except for cardiac transplant. Our cardiac physicians are pretty much doing everything when it comes to cardiac. And if it's something new, they're training to do it, and they'll be doing it soon. The only thing we don't seem to be doing well at our hospital is taking care of heart failure patients, unfortunately. Our readmission rate runs about 24%. We've been penalized for every year that I can remember. I don't know a year probably we haven't been penalized, it seems like. We currently are at the highest rate of penalty of CMS right now at 3%. Our list resulted in, before COVID, when the penalties were penalized, we actually had a $500,000 penalty or a lack of reimbursement. But there actually is a greater loss because you actually lose reimbursement percentage from Medicare as well. And my understanding from some of our executives, actually, we probably lose a little over $1 million a year due to this heart failure readmission rate that we have. Back in 2019, we started to work on this and bring in the REDS. We were all gung-ho. This was supposed to go to Capitol in March of 2020. It was on the agenda, and that meeting got canceled because of COVID. And with that, everything came to a standstill. So the VEST was ready to go, and we were going to hopefully adopt it. It was going to be approved, and everything came to a screaming halt. Next slide, please. So finally, I won't say COVID's over or things back to normal, but sometime late this past summer of 2020, we finally got that approved through Capitol, and we ended up purchasing 5 vests. With this, our plans finally came to tuition, and part of this was rolling out with a whole new CHF readmission protocol at our hospital. And with this, we brought in 2 major changes to our protocol. One was a diuresis algorithm involving a Q8-hour dosing of Lasix, which actually involves the nurse actually changing the dose of the Lasix based on the patient's urine output. But the other thing was the REDS Pro readings. That was the big thing that we brought in. And with us, we're doing a daily reading at our facility with the REDS Pro. As soon as they come in, they're supposed to get an admission reading, and then one every morning after that. We use the devices on our cardiology floors at our hospital, B3, B4, and B5, and at our Hollis and Pablo clinics. At our Pablo clinic actually has our rapid follow-up clinic for our post-discharge heart failure patients, so they're using it there as well. That clinic, actually, we kind of reopened it up again. We closed it during COVID. We just recently reopened it back up in this past December. And so we're starting to see patients now starting to use the vest with that as well. Our goal really is to discharge patients dry using the vest. And with this, we use a target range of 35% or less. We understand that not all patients possibly can reach that goal. So we also have put a caveat there with a baseline percentage for those who have heart failure that has New York Class 4 or ES 15%, that may only be able to get down to 37, 38% as well. And hopefully with those patients, the more we see those patients, the more we have that documented, so we know what our goal is as we move forward. Next slide, please. Like I said, we're in the beginning stages. We still are doing a lot of learning. Our experience with the vest, I was the main driver of this at our facility. I have a very good relationship with our cardiologist. I worked with them, brought the vest to them, spoke to them about it, had majority buy-in, had some on the fence, but they were all willing to look at it, and they were willing to go forward with this project moving forward. But at our facility, we don't really have a necessarily dedicated heart failure floor or plan, I guess, or cardiologists just see our heart failure patients. At our facility, the majority of heart failure patients are seen by the hospitalist. So I had the cardiologist come in, but then I had to convince the hospitalists on how to use the vest and train them and teach them how to use the vest and get their buy-in. And that was a whole group of much more physicians I had to go through. So that was a huge challenge in itself to get them to come along, which was I would say somewhat challenging, but they were lend me their ear and they were willing to listen to me, and so far it's worked out okay. The other thing we had was nurses, and I say so many nurses because the fact that when you have 3 floors of cardiology nurses and you're talking about 120 plus beds, a lot of nurses to train using the vest. So with this many nurses and the vest having some particular on using it, making sure the nurse puts on a patient correctly and appropriately and stuff, you kind of get low quality, you get some changes there. So it's important that it was just it took a lot of training and retraining with nurses coming and going as well. It takes time and something we're continuing to work through even at this point. The other thing with the patients at our hospital, because of the fact that it's one thing at a clinic, I guess, using the vest where a patient is more able to cooperate with you, able to sit up and stuff. Sometimes at a hospital, patients can be too big, too frail to actually sit up, and sometimes it takes 2 people to use the vest. And like you said, sometimes patients are too skinny as well. And we have patients absolutely refuse. And sometimes this might be an issue because we're doing it maybe too early in the morning. Nurse managers felt and physicians felt that we should do it early in the morning when we first doing seeing these patients, like at between 4 and 5 in the morning. And sometimes patients don't necessarily want to be seen that early in the morning. And with this, we've had some inconsistent readings that we're still trying to work through, and we're trying to figure out why. But at the same time, we actually have some data is actually looking pretty good. When we have consistent readings on patients that are consistently going down day after day, like they're supposed to, and they're being discharged appropriately with a 35% or less, which I can't say right now 60+% of the time that's happening at our facility right now. The preliminary data is looking promising. Our 30-day readmission rate is trending down, and then it's looking good. So I'm hoping that at some point in the future we will have some hardcore data that shows that our 30-day remission actually is down and going to stay down and continues to trend down as we go in the future using the ReDS Pro vest.
Kevin, you've really been a leader down there. We've had multiple sites, including ours, see 30, 40, 50% reductions in heart failure readmissions. And some sites have even reported numbers similar to what we've seen in the original Israeli study, with up to 70% reduction in admissions from a 24, 25% down to 12 or 14%. So you've really been a leader bringing it on there. The thing I'm most interested in about is you managed to convince your administration to say, hey, listen, we have a problem. Year after year, you were getting 3% Medicare penalties. Many, many hospital systems around the country are getting 2 and 3% Medicare readmission penalties. How did you bring the administration to say, hey, this is the right thing to do and this is worth doing? Who was your key partner? How did you get the buy-in?
I think one of the biggest thing is that I think the CMS penalty, as it increased over the past 5 to 10, was about 10 years ago, really I think started to take notice with them as well. And we started to reach an inflection point where really it was hurting us not only financially as well, but it was also hurting us because it was showing up in the papers too. Every year, it shows, hey, our hospital is being, penalized for this, this, and this. CMS is this much money, and it does not look good at your local paper as well. And it's not like we haven't tried. It's just we just never really gave it a really good effort, I think, and really never had a good, we never had a good plan or a good device or something to really get behind.
Right. I think studies show clearly that even in the best centers, 30 to 50% of patients are leaving the hospital still fluid overloaded because it's just so hard. The symptoms are gone before the lung water is gone, and that sets up people to get readmitted. So thanks, Ken. That's just phenomenal. Great work. Keep it up. We look forward to seeing some published data.
Thank you.
In the interest of time, we're going to roll to our last speaker, Jenny Guevara. Jenny is a nurse practitioner. She's a lead advanced practitioner for cardiovascular care at St. Barnabas Medical Center in New Jersey. And Jenny, welcome. We're excited to see your data.
Great, thank you. Is everyone able to hear me okay? I had some problems before. Okay, great. Thank you. So thank you for the introduction. So I work at it's about a 500-bed community teaching hospital in suburban New Jersey. All of our patients who are admitted with acute decompensated heart failure is seen by a nurse practitioner specializing in heart failure from one of our team members. Their job is to see all the patients, make sure they receive adequate education on their self-care, make sure they get the proper services upon when they leave, and ensure that all guideline-directed medical therapy is adhered to. And our team sees an average of about 900 to 1,000 patients per year. Next slide, please. So after we had we're able to get REDS, we have the REDS vest. This is kind of the protocol that we came up with our chief of cardiology. We do a reading within 24 hours of admission, preferably day of admission, as close to the ER as we can. Reading on day 3 of admission to kind of assess how we're doing with diuretics. How are we doing on day 3? Do we need to go up? Are they actually euvolemic? Do we need to do more? And we do a reading on the day of discharge, preferably, or within 24 hours of discharge. And we just conducted an evaluation to identify if there was an improvement in 30-day all-cause readmission rates and length of stay compared to a historical control. Next slide, please. So we conducted a retrospective chart review on all adult patients admitted with a primary diagnosis of acute decompensated heart failure from January 1st, 2018 to September 30th, 2019. Our REDS cohort had consisted at that time from May 1st, 2019 to September 30th, 2019. And I apologize, I just realized there's a typo in the first one. That should be 2018 in the historical control. So, okay, we examined everyone who had the REDS data and was documented in the electronic health record. We put it in we were able to have it changed so we could have it as part of the vital signs. So when any of the, especially the physicians or myself or any of my advanced practice colleagues would document in a progress note, when we click on the vital signs, the REDS reading would upload into the progress note as well. So any exclusion criteria, we excluded anyone receiving hemodialysis or any other renal replacement therapy, just because we knew we wouldn't be really adjusting their diuretics at that point with the REDS vest. And we excluded them if they had expired, because an expired patient isn't going to be coming back, basically. So our REDS cohort consisted of 220 patients, and our historical control is 196 patients. And we analyzed clinical characteristics, including demographics such as age, gender, BMI, ejection fraction, and smoking, and looked at cardiovascular diseases, diabetes, hypertension, chronic kidney disease. Looked at laboratory values and analyzed BNP, serum creatinine, sodium, potassium. And the primary endpoints were the all-cause 30-day readmission rates and length of stay. Next slide, please. So when we did analyze all the data, we found that the majority of the baseline demographics were not statistically significant. So we had a really good split between the control and our cohort. The patients in the RED group did have a tendency to be a little older and a little more likely to have a history of hypertension, but it was very small. What we were able to find is that our REDS group had lower all-cause 30-day readmission rates as compared to the historical control. The REDS had a 16.4% readmission rate versus a 25%. What we did not find was any statistically significantly different length of stay between the groups. It was slightly lower, but not significant. However, that also, there was worry that because we were doing it upon discharge, that it would increase our length of stay. And that is not something we found. We found that, I think doing that day 3 was key also, because it gave us a chance to also increase the diuretics at that time also. Next slide, please. And again, this is just graphs kind of showing just what I said, that our REDS cohort had a lower readmission rate than the control, and our length of stay was really identical. I mean, 6.27 versus 6.3, I can't even stay that it's less really. It really is identical, but it's not more either.
I think, the data here, Jenny, is really great. You make one of the points you made is actually one of my favorite points of this whole presentation, is that identifying the volume status early in admission is really important, because what often happens is a hospitalist or someone else will spend 2 or 3 days trying to figure out, are they really volume over? Did they respond to Lasix? What did they do? Identifying the patient's degree of volume overload up front. In one of our programs that we found that patients who we diuresed an extra 7. The hospital said they're ready to go home. We jumped in with a ReDS device and said, wait, they're not ready to go home yet. And on average, we took another 7 pounds of fluid off of them. And so we actually increased their length of stay by almost 2 days. But in a further study, what we showed is that if we got involved earlier, helped them determine the volume status earlier and be more or less aggressive with diuresis, we could get the same benefit without increasing the average length of stay. So I really appreciated your point that getting involved early, you can get these outcomes without worsening length of stay. We have a few minutes left. There's 3 or 4 minutes left. I'd like to thank all our speakers for their experience, and I'm excited to see the data as it matures and we really build a larger and larger database. In our system, we couldn't imagine practicing heart failure now without a device to be able to measure point of care. We're also big CardioMEMS fans. We use a lot of the device and we feel like it's a good device, but you can't use it point of care. It has to be implanted beforehand. So this is the one device that gives us much the same information, but anywhere, anytime we want it. So there's a couple minutes left. I'll open the floor up to any of the participants or the listeners here for any questions. You can put them in the chat or just please speak up. The stage is yours. And John, I can't see the chat, so if there's things coming up in the chat, if you want to present them, John or Ron, if you want to present anything coming through the chat, please do so.
I just have Gretchen just asking about possible to share the slides. But I think we'll work on that for sure.
Yeah. And there's we are also more and more data is being published. Sean Pinney, who's now the director of heart failure at University of Chicago, just had a nice paper published. Our group just had a nice paper published on discharge. They did an ambulatory clinic there. The data is really growing. There's now some ER data looking at ER diversion. So I encourage you to also go to the data or contact John, who can provide you some more links to the new data that's coming out. We have found that hospital systems, when we try to employ this, the hospital systems, they're really looking for, look, how can you bill for this? What can you do? Where we're partnering with ACOs and payers, one of the ACOs and payers, they get it. The benefit here is keeping people out of the hospital, saving money, and really the cost savings associated with earlier treatment and more targeted treatment. With respect to everyone's time, unless any of the panelists have any further comments, I'd like to thank everyone for joining and wish you well. And if you need any more information about this technology, I'd be happy to discuss.
Doc, will the slides be available in any way, shape, or form? The information provided here, or even the recording, is that something that that the public can reach out and get somewhere?
Yes, I will, Dan, if it's okay, I will collect the emails on this webinar, and I would send everyone a message with a link to the recording of the webinar and the presentation.
Wonderful. Thank you. Very well done. Thank you.
Thank you so much for all the participants, and especially for Dan and the panel members. Really appreciate it.
Good night, everybody. Take care of yourselves.
Thank you.
Thank you.
Bye-bye.